So heart failure is a condition due to the chronic assault, due to the coronary artery disease or the hypertension or the lifestyle modifications what we have made, and we should not have done those what? Sedentary lifestyle habits or the habits which can affect the coronary arteries. With all this, we have started that congestive heart failure is a condition where heart is drenched in its own secretions and the heart is no longer able to pump the blood according to the needs of the body or the metabolic needs of the body, and if it can do so, will be with the more pressure or with accessory hormonal influence. Okay, with this effect there will be changes in the heart, modification of the heart. That modification we call it as pathological changes. Okay, with this initiative we told that there are different types of heart failures. It may be right-sided heart failure or left-sided heart failure. It may be systolic heart failure or diastolic heart failure. Okay. So what is the definition here? Impaired cardiac pumping such that the heart is unable to pump the adequate amount of blood. How does the patient present to us? The patient can present to us with starting from head to toe. Okay, there is no supply or lack of supply to the brain. The person may be dizzy. If the person coming to the respiration, he will be tachypneic because there is no oxygenation taking place. Then dyspnea, agitation, cyanotic, cold clammy skin, severe dyspnea, fatigue, paroxysmal nocturnal dyspnea. All these things will be there, and by look-wise, the patient will be edematous. Okay, it may be bilateral pitting edema, ascites around the abdomen. All these things will be there. Then, what are the risk factors? Age is the main risk factor, and along with that, the lifestyle what we are adopted, that may lead to the hypertension, obesity. Okay, so smoking and alcohol, they can add to the problem. Then we can have the congenital or the genetic predisposition to the cardiomyopathic conditions, restrictive, dilated or hypertrophic. So we have two types here again, okay, that is acute and the chronic. But chronic, there will be chances of compensation. In case of acute, the problems of death will be more. This chronic can again present as an acute precipitation also. So coronary artery disease, hypertensive, rheumatic, congenital, cardiopulmonary, cardiomyopathy, anemia, bacterial endocarditis and valvular disease. What is cardiopulmonary? Anyone went? Sure? It is related to pulmonary hypertension. What is pulmonary hypertension? It is due to the respiratory problem. There is right ventricular problem. Okay, the right ventricular problem caused due to the pulmonary disease. Okay, that can lead to pulmonary hypertension. It is rather other way. Okay, cardiac disease due to pulmonary cause. So bacterial endocarditis, valvular disease, all this. Acute conditions, we have ventricular septal defect, myocarditis, hypertensive crisis, thyrotoxicosis. So we have described this cardiac output and how it will affect. We told that let it be the normal amount as 100 ml, the 70 ml should be expelled out to the peripheral. So we calculated it to be approximately 5 liters per minute. So if something less than this is decompensated, and this decompensation of output we call it as systolic dysfunction. Diastolic dysfunction, in diastolic dysfunction the ejection fraction may be normal as 70%, but as the volume it has received itself is less, there can also be diastolic dysfunction, cardiac failure, even though ejection fraction is normal. So we have told about the systolic dysfunction and the diastolic dysfunction. What is systolic dysfunction? The heart is unable to pump enough amount of blood to the periphery. And what is diastolic dysfunction? It may be due to the concentric hypertrophy or due to the incomplete filling of the what? left ventricle. Okay. So with all this, so without this assaults happening under predisposing conditions, there can be myocardial injury. This myocardial injury may be due to the myocardial infarction. Okay, MI. A small MI has occurred and a small part of the tissue is dead. What happens? That part is not able to contract efficiently. So once it is not able to contract efficiently, there will be pathological remodeling of the heart. Okay, so the heart will try to compensate. There will be fibrosis of that part. Okay, then there will be what will be happening? There will be low output. So low ejection fraction can relate to death, or if it is a chronic condition, there is some compensation there. It can lead to chronic heart failure and present to us. And there will also be neurohormonal changes which we have discussed. So what happens when there is low output or there is less blood in the circulation, or blood is circulating slowly? There will be the activation of baroreceptors and chemoreceptors. Once the baroreceptors and chemoreceptors are activated, what can happen? There will be renin-angiotensin activation. Okay, what will happen? Then angiotensin 1 to 2. Okay, then this angiotensin 2 it can stimulate the mineralocorticoid and also do the peripheral vasoconstriction. This system will be helpful if it is if the heart is normal. But if the heart is not functioning normally, this system may be acting as a vicious cycle, increasing the load for the heart. Okay, how it increases the load? By peripheral vasoconstriction, more blood is pumped to the blood, more blood is pumped to the heart, and there is sodium water retention. Again, preload will increase. So there will be more cardiac workload in the decompensation already which is existing there. Then there will be heart failure. In this case, when the plasma volume is increasing, salt and water retention, and cardiac workload is not occurring properly, not taken care of properly, what will happen? From the plasma there will be percolation in the peripheral tissues. It may be in the lung and the subcutaneous tissue, which can lead to peripheral edema. So we told that the X-ray picture of the congestive heart failure, how is it normal distribution? 1/3, 1/3, 1/3. But here you can see it is almost occupying the half of the field. Okay. So this is the American Heart Association classification. Based on the stage the person is presenting to you, we can use 2-drug combination, 3-drug combination, or an inotropic drug. Okay, so first will be asymptomatic or symptomatic with moderate symptoms, then with minimal exertion, first moderate exertion, then the person will become symptomatic at rest. So this is something similar to our angina stages, which you might have already learned. Here there is at high risk, no structural change, but here there is structural change, no signs, symptoms. Here structural change plus symptoms, and here there will be a condition where the person is refractory to the treatment. Okay, in case of refractory cases, we can think about the cardiac surgeries and artificial hearts. So where our drugs can act. Okay, so our drugs can act at 2 important stages, that is preload. They can decrease the preload or decrease the afterload, and also if both are not helping, because the drugs which are acting as a preload decreaser or afterload decreaser, which we have already learned, that means most of them are antihypertensive drugs which we have already come across. But those drugs which are acting on the heart directly and increasing the contraction, those drugs are little bit more dangerous to use or should be used with caution. So the first line of drugs will be those which can decrease the preload or the afterload. Once you are not able to do with that, you will shift over to the inotropic drugs. Okay, so here are the drugs. Preload means input to the heart, it can be decreased. Okay, those are vasodilators. It can also be the nitrates. Okay, nitrates, all these things, hydralazine, all these group of drugs. Then how can we